Hello and welcome to the YouMatter podcast. This is episode 1. Hi and welcome back to the YouMatter podcast. I'm Jo Turner, and this month we are talking to Dr. Adam Harrisson about the concept of professional identity. Now, Adam has been a doctor, a lawyer, a medical director, and now a coach. So he's very well qualified to talk about transitioning in and out of various professions, and with that, probably adopting a few different professional identities. Please go and find us on social media. You can subscribe to our channel on any platform, depending on your preference. And if you're listening to us on iTunes, then why not give us a 5-star rating so that more people can listen and benefit from the podcast. I really enjoyed recording this episode with Adam, and I hope you'll enjoy listening. Please do give us feedback. I'll be back at the end of the session with a little bit of a closing roundup. Welcome. I am thrilled to be here with my good friend, Adam Harrisson. Adam is a doctor turned medical director and now also a coach. I say Adam's my good friend, and he is, but actually we've never met in person, partly because he currently lives in New Zealand, but also because we met and became friends on LinkedIn. So way back early in about May last year, I was having a slightly difficult conversation on LinkedIn, and Adam, who knew nothing about me but was very knowledgeable on the subject, came in calmly and sorted things out, and it all moved along beautifully. And now that I know Adam better, I know that that is very typical behaviour of his. So with all those professions that Adam has moved through, he's really well qualified to be my guest on this podcast about professional identity. And Adam, if you would you start by giving us a little bit of your background and some of the history that led you along these various pathways?
Yeah, of course. Thanks, Jo. Can I just start by saying thank you so much for inviting me on to be a guest on your podcast, especially as it's your first episode. I can't tell you what an honour and a privilege it is. So thank you so much for that.
You're very welcome.
Okay, so I'm from Birmingham originally. My parents are both working class. I went to state schools, went to a few primary schools because my parents moved around a bit due to they got divorced and my mum remarried and so on, so we moved around a lot. I went to a grammar school for secondary school. I was very academic but not particularly sporty. I did a lot of drama. That was my main creative outlet. But from the age of about 13, I thought about becoming a vet, and then it kind of moved along a little bit into either a vet or a doctor. And then I did some work experience in my local hospital when I was 15 and firmly decided on medicine after that. I did very well in my GCSEs, but took my foot off the pedal in the lower 6th and didn't really do much studying. Now I think about it, maybe I was a bit burnt out from working so hard in my GCSEs. Mm-hmm. So I didn't do very well in my A-level mocks. I got 2 C's and an E, the E being in physics, but still managed to persuade the head of physics to predict me a B so I could get offered med school interviews, and ended up getting what I needed to get into medical school. I actually had a year out and started med school in 1994, and I messed up my first year at med school. Not quite sure why. I think it was just being a fresher and getting carried away with all of the things associated with that. I failed a couple of subjects and joined September Club, which for your listeners not familiar with that term, I don't know if it's a med school thing, but it basically means that's when you did your resits in September. And so I'm a lifelong member of September Club, that's for sure. And it was while I was revising for my molecular biology and genetics resit, studying it for the first time actually, that I had a moment where I thought, if I fail this exam, then my hopes of being a doctor are over. And then what am I going to do? with my life. And I also felt that I'd be letting my parents down if I failed med school. So suffice to say, I studied hard and passed the resits with flying colours. Beyond that, I studied history of medicine for a year at the Wellcome Institute, and that was easily my favourite year of medical school. That was just a wonderful environment and fascinating subject area to look into in more detail. Really enjoyed my clinical studies, loved all of my placements, which probably meant I was a bit of a born GP, I guess, in retrospect. And I was generally happy at medical school. Took me around 6 months to find my tribe. But once I did, I've had such a solid group of friends, and now we're all in our mid-40s with children, and we still meet up every year. Obviously not at the moment, but we had done up until coronavirus. So yeah.
Can I just take you back a bit, Adam, because it's that's an interesting pathway through school, and a little bit of a pattern of maybe it's a bit rude, but a little sort of stop-start, maybe not being quite sure about when to put your efforts in, and then these periods where actually you really put your foot on the pedal and decided this is what you wanted. Yeah. So I'm interested, there was obviously some point at which the idea of being a doctor drew you. Do you think there was anything about professional identity, even when you were a young boy? Did you have some idea of, was that what was drawing you on, or something else?
So I was the first in my family to go to university at all, let alone medical school. So I didn't really have any obvious or immediate graduate or professional role models to look to. The only doctors that I could have looked at with regard to noticing their professional identities were my childhood haematologist, because I had a blood condition, and I spent some time in hospital as a young child, and had to go to a lot of outpatient appointments, and I had to have my spleen removed when I was 5 or 6. So I think, that may have had some kind of lasting impact. I'm not sure. I've met a few doctors who had been hospitalized or had a lot of contact with hospitals when they were children. And other than that, it would have been just my GP, who I didn't see that often. And one of my best school friends' dads was an anaesthetist, but he was living in and working in Leeds. And as I say, we were based in Birmingham, so I didn't really see him very often. So I didn't really come into contact with doctors that frequently in my formative years, not enough to identify with them, and really become impacted by their professional identity, if you like. My mum worked as a GP receptionist at the time I was doing my GCSEs and while I was in the 6th form. But then I didn't really have much to do with her employing doctors either. So I don't know, having not had that, heavy or frequent contact with doctors, I guess I wouldn't really have ever thought I had anything in common with doctors, due to my working class upbringing, I mean, I obviously...
That's an interesting point. Is that do you think at that time you might have thought people from my upbringing don't become doctors?
Yeah, I mean, possibly, yeah. I mean, I certainly wouldn't have been able to identify with their lifestyle, for example, and there were some families like that at my grammar school, because quite a lot of the class were, parents had medical or legal jobs or whatever, and my parents had kind of normal jobs, if you like, but somehow I developed an interest in it enough to go off and do work experience in my local hospital when I was 15, and then I spent some time in my mum's GP surgery where she worked, and I went to a conference called Medi6, which was run by Nottingham University. It was for sixth formers interested in medicine. So I guess the interest came from somewhere, but I can't really put a finger on it. I mean, obviously going to grammar school, medicine was a possibility, at least. If I'd gone to my local comprehensive school across the road, that it may not have been even an option or something that crossed my mind, because there are some schools and some teachers that just don't encourage their students in that way. So I don't know. I think I was lucky to be at grammar school and be in contact with people whose parents were doctors, I guess.
Yeah.
I mean, I really enjoyed science, and I think I had a caring disposition. So maybe that helped me identify with the idea of becoming a doctor.
Yeah.
But for sorry.
It's interesting, isn't it? Sorry to interrupt. I'm just thinking about when I grew up, and very interesting that you follow these two careers, but I sort of had in my head this, I don't know where it came from, but this unwritten belief that doctor, lawyer, they were the big stamps. That was what clever people did, and those were the most obvious ones to start with. And I hear that you're saying when you went to grammar school, a lot of people's parents followed those two professions. I mean, that's talking from a child's perspective, but do you think there's a commonly accepted identity by the public of doctors? Let's say doctors rather than lawyers.
I think that's a really difficult question to answer, as I imagine there's a lot of variability in how different members of the public might answer that. So, I mean, I'd like to think that most members of the public see doctors as caring, helpful and skilled people. But there's always going to be some people that will see them as dismissive, abrupt, arrogant, depending on their patient experience. I think that's what dictates how people perceive professionals, is their own personal patient experience.
And I think two things, isn't it? When you're younger, maybe you have this idealized view, and then maybe your experience might change that or influence that.
Yeah, absolutely. But then there's a sort of extraneous influences like the government and the media. For example, when the junior doctors were striking, it was all over the Daily Mail that there were MOE medics around and doctors were being portrayed as fat cats, and how dare they contemplate striking and so on. They don't care about their patients, they just care about their income and stuff like that. So
what's MOE medics? I don't know that term.
Yes, so I think it was in the during the junior doctors strike a few years ago, because of their kind of working and pay conditions, and the junior doctors contract was being renegotiated by the British Medical Association. I mean, I'm sure the government influenced Murdoch's press, like the Sun and the Mail and whatever, to publish photos of doctors on their holidays and on their electives and whatever, and skiing, drinking champagne. Okay. And so there's this thing of MOE medics.
I see, sorry, MOE as in the champagne.
Yeah.
Okay. I thought it was an acronym.
So yeah, I mean, these things have considerable influence on public's perception and their opinion. So it's powerful stuff. So yeah, I mean, it's very hard to say, what the public genuinely think, but I hope most of them see doctors as caring, helpful and skilled people.
Yeah. Yes, those are hopefully the things that draw people into those professions, aren't they?
Yeah, definitely.
Have you ever felt at odds with any of the sort of perceived professional identities? And I know you were talking in broad terms there, and maybe it's those ones I'm referring to. Have there been points in your career that you felt at odds with that at all?
So I think firstly, my perception of doctors is probably a little bit more specific than what I would imagine or would hope the public's to be. So I would see them as being intelligent, conscientious, caring, skilled perfectionists in the main. But that concept is probably skewed by my patient experience. So how I was talking about, the public's patient experience influencing how they might see them. For me, on the whole, doctors tend to look after other doctors really well. So when I've ever had any patient encounters since I've qualified, I've been treated like beautifully by my colleagues. So my perception is a bit more.
Do you think that was different because you were a doctor? I guess you can't tell because you haven't.
I would say it was, because they always, ask what you do, and then kind of the conversation flows in a certain direction. So, but if we take my perception of doctors, then yes, I've certainly felt at odds with that at various times during my career. So I've been through some dark times during my medical career. I have been bullied by colleagues several times. I actually did a podcast interview with Dr. Rachel Morris, and we talked about bullying. And I thought before that interview of at least 8 incidences where both as a junior surgeon and as a junior GP. I now, looking back, I feel that I burnt out at least twice that I know of. And there was one surgical job that I did where I was essentially given the cold shoulder by the entire rest of the team. I wasn't a formal official surgical trainee, and so they wouldn't let me go into theatre and operate. That preferentially that was being given to the official trainees, and they were very, very cliquey, and it was a very lonely, dark time. So during those times of being bullied and burnout, I was definitely not conscientious or caring in the way that I felt a doctor should be. But I didn't seem to care that I wasn't. I had the insight to realize that I wasn't embodying those characteristics, but I was so distracted by the stuff that was going on with me that I could not fully invest myself in the role.
That's really interesting. Do you think there's anything in that the other way, that the only way to fully be engaged externally is to be not engaged with what's going on with you? Or do you think that was just such an overwhelming situation that it overrode any of your normal ways of operating? Lots of questions.
That's a really good question. So I always say to colleagues that the doctor-patient relationship is fundamentally, at its core, a relationship between two humans. Mm-hmm. And we all have baggage that we'll bring to work with us. That is unavoidable, and as professional as we think we are or try to be, sometimes things are just going to prey on your mind, or even subconsciously, and it's gonna affect you. You've had a blazing row with your other half, or your kids have done your head in particularly badly on the school run that morning, or you're going through financial worries, or a legal suit or something. Do you know what I mean? There's always some. I think you can't ever push all those things to the back of your mind, and if you think you have, then I think you're kidding yourself. I think these things will have a subconscious effect on you. So yeah,
it's a really interesting point, and actually leads into a question I was going to ask you next about perhaps the relationship between perceived identity and our own well-being as health professionals. And I was just, as you were talking then, I was just very mindful of my behavior as a physiotherapist. And quite genuinely, and I believe this, I've said to people, one of the things I love about my job is whatever's going on for me personally, I cheer myself up by being a physio at work, because, rightly or wrongly, I think one of the perceptions of a physio is that we're generally pretty easygoing, happy-go-lucky people, and that's a massive generalization. But that's, to me, that's one of the perceived identities of a physio, which genuinely is great, because I know that many times in the past I have, maybe not consciously, but as I've walked through the door or into the clinic room, that persona has switched on, and I become physio me. And that is it's not an inauthentic part of me. It's definitely part of my personality. But I hear what you're saying. Sometimes when there are significant things going on, if every time you go in front of a patient, or perhaps every time you walk into your place of work until you leave, you're switching that stuff off and burying it. As a doctor, I mean, one of the things you listed there was if there's a legal case going on. And that's huge. That's more than a bad school run, isn't it?
Yeah.
And I get you. I wonder if the extent to which we do that over time, maybe it's the chronicity of that behaviour which perhaps doesn't serve us quite so well.
Well, that's interesting. Again, bringing up that legal point, because if it's and I wasn't actually deliberately alluding to anything kind of with a clinical negligence bent. I was actually just thinking, there might be something you might have been
do you commonly get
accused of a crime, or I'm just thinking of like really severe life events, divorces, they're legal proceedings, but that's that kind of clinical negligence thing would definitely affect you at work, and it's the same with a patient complaint or any action by the regulator, so the General Medical Council, or it's the HCPC for physios, because that is, we have this thing about regret bias. Are you familiar with that?
No, concept? Can you explain that one?
So if you have done something, you've treated a patient in the past and there was a problem or whatever, then you will always be uber conscious of that and extremely careful for that not to happen again. So it will actually affect your practice in that you become too careful and too defensive and over investigate more, because you're at pains to not make the same mistake that you made in previous years or whatever. And it sometimes only has to happen once for you to experience that regret bias. But if it's like, you're being sued because you didn't treat someone correctly, in their opinion or in their lawyer's opinion, then you will definitely bring that to work, because you'll be so conscious of, right, okay, so this legal case is about me not prescribing the right hypertension medications or whatever, so I'm going to be really nervous about hypertension patients from now on. You know what I mean? It's you're definitely you can bring that to work with you for sure. So
it sounds like hypervigilance. That would be a phrase I'm more familiar with.
Yeah. So we're talking about well-being and fulfillment.
I'm conscious that YouMatter has a very strong focus on the well-being of the clinician. And I know you and I have talked privately a little bit about whether certain aspects of identity serve us well in that context or not.
So again, I think the answer to this is dependent on the individual professional. I think some of us will receive all the emotional fulfillment that we need through our work, but this doesn't necessarily correlate with physical or psychological well-being, of course. But if you're, you hear about people talk about their work being their life. If work is your life, then logically it kind of makes sense that your professional and personal identities are almost merged.
Yes.
If your work life and your personal life are merged, then your identities will as well. But for me, I receive a sense of well-being and fulfillment from having a good work-life balance. I love my work, but I love my family and my relaxation time more. So I don't personally really think about my work-life identity, my professional identity, when I'm busy in my personal life, which I find fortunate, because I know some doctors who just can't separate work and home life, and they can't switch off when they're at home. I will know doctors who worry about mistakes or omissions that they imagine that they have made with patients at night, and then they can't sleep properly. So there's a sort of paradox there, for me anyway, because I can go home and not have work intruding on my home life, because I just don't think about it. I'm very good at separating those two off. But I will certainly bring home and personal life stuff into work. And I don't know why I do that. I don't know why I can control it one way but not the other way.
And was it always that way, as in not bringing work home, or is that something you had to teach yourself to do consciously? What do you think?
Yeah, I think I've always been able to to do that. Okay, in a 19-year medical career, there might have been 2 or 3 occasions where I think, oh, I think I shouldn't have prescribed that antibiotic or something. I think that child was allergic to penicillin, so shouldn't perhaps have prescribed it cephalosporin or something like that, something along those lines. And then I'll have a bit of a panic. And then the next morning I will go into work early, and the first thing I will do is phone that patient or phone that parent and say, I'm really, really sorry. I think I might have done something that was a bit, remiss. But that has literally happened sort of 2 or 3 times in 19 years. But this is probably a massive generalization, but from what I hear from colleagues, I think male doctors are much better at switching off after work than female doctors.
Okay. Do you think there's any time the other way around, that it might be useful to take some of the traits that you've identified as the sort of typical identity of a health professional? Do you think there's any time when it's useful to take those into life outside work? I suppose the simple question is, has the identity of doctor served you in your personal life?
Yeah. So firstly, I think, you're talking about taking your professional identity home, and I think that's different from taking your work home with you.
Yeah.
And again, I think this depends on the individual professional. So for some people, it's going to happen to a greater extent than others. Personally, I don't know any doctors, and this might be the self-selection of the people that I mix with. I don't know any who adopt their work personas at home. But I think there are times when we actively turn to our professional identity while we're not at work. And I would liken this to, a mask which we can turn to and don if, for example, we're feeling insecure and we want to portray strength, skill, or bravado even. So, there might be some doctors who will boast about their work at a party or something like that, because maybe they're feeling insecure, and it's like, well, this is the best part of me. This is the part of me that people really look up to, not just, boring old Adam without his doctor hat on. So I think it could be something that people turn to when they feel they need something.
I know what you mean about I remember driving home, distinctly remember driving up the M5 from Bristol, going home to start my first period of maternity leave. And I hadn't really thought about this at all until that moment. But I just remember getting this thought, oh my goodness, for the next 6 months or however long, I'm not going to be a physio. So who am I? And I found that really shocking. I mean, had I known how all-encompassing the mother persona was about to be, then I probably wouldn't have stressed so much about it. But I wouldn't have said I was someone who was so invested in my professional identity that I had nothing else. I had loads of interests outside work, but it wasn't upsetting to me. I guess just surprising how strong that identity was within me. I don't know if obviously you've never been on maternity leave. You've had periods of
vicariously. That's really interesting that you should say that, because and this was surprising to me as well, but there was a time that I very clearly remember as well when I fretted about losing my registration because I considered my professional identity to be that of a practicing doctor. So back in 2010, I'd worked as I'd left clinical practice for just over a year. I worked as a medical legal advisor for the Medical Defence Union. And it was for almost a year. And I wasn't happy in the role, not because the work wasn't interesting, but because of the employer. And I was home working and there were various things going on. But at that time, your registration as a GP expired after 12 months out of clinical practice. And it was part that I wasn't enjoying working for the MDU as much as I'd hoped I would. And I wasn't happy in that job. And part the thought that I was going to lose my legal right to prescribe. So as a doctor, and as a GP, you can't prescribe absolutely everything. So there's some like cancer drugs and things like that that you can't prescribe, but I could prescribe almost anything from the British National Formulary. And for me, being able to do that defined me as a doctor. So to prevent me from losing that legal power, I resigned from my role at the MDU just before that 12-month and returned to clinical practice.
Quite a significant step.
Yeah, it was really a potent feeling. Yeah, I'll never forget how I felt at that time.
Yeah. So that's quite interesting, Adam, and it makes me think a little bit about a situation that is going on certainly in physiotherapy and to a certain extent in other MSK professions. And when I say physio, I'm probably talking more your kind of musculoskeletal outpatient physio. So actually this situation has been going on for most of my career, but it's gathering pace now in that there's quite a shift. So research progressively has proven that a lot of the hands-on mobilization passive techniques that people of my era were taught as almost exclusively your toolkit at college, the more research that comes out, it just shows that the effects that we were taught that were going on with tissues and joints are just not happening at all. And it's not to say that there's no benefit in putting our hands on patients, but there's a real shift towards using our hands to guide movement, or there's a phrase therapeutic touch that has come out. A lot more emphasis on a holistic or biopsychosocial approach. So taking a lot longer on your subjective, really making sure that when you assess somebody, it's in the context of their life in that moment, rather than a generic back pain presentation and then a recipe of treatment. And these are all good things. And frankly, this far into my career, I've been waiting most of that career for these kind of changes to take place. But I guess for the last, probably particularly the last 5 years, there's a sense of unease that seems to have developed in the profession. We're not great at debating things. We're not particularly comfortable with conflict, so it seems to take us a long time to work through things. And I would say that it, at the moment, is causing a little bit of a professional identity crisis, particularly for MSK physios. So I don't know if that's anything you're aware of. And it'd be interesting to ask you, actually, if you as a doctor were referring for physio, particularly for MSK physio, would you have been aware of this shift, or would you still imagine that we would largely be getting the patient in the room and delivering passive techniques and then maybe teaching some exercises? What would your understanding be?
Yeah, definitely the latter. Not really aware of any updates or changes in the way that physios are practicing, probably because we don't get to interact too much in primary care. Some doctors like orthopods, rheumatologists may be a bit more aware of that, but I think GPs almost exclusively just refer in and let you guys work your magic without too much awareness of what you're actually doing.
I think that's exactly it. It can seem like dark arts, and even within our own profession, sometimes I think we think some of the things that other physios do fall into that category. Okay. So I mean, it's interesting. We've got a lot to work through ourselves, and then clearly the next stage is to start telling other people, including our patients, where we're going and what our identity actually is. And I think that will be a great place to be, and improve confidence in the profession, I think. So maybe a little bit of a diversion, but do you think, what do you think about, I guess I see a slightly changing environment in that, particularly with doctors, there used to be this very sort of distant persona. Doctors to me when I was growing up were important people that you didn't ask questions, you just listened to what they said, and it was definitely that on the pedestal thing. And probably early in my career, I think I'd still behaved with consultants and people that I perceived to be on that pedestal in a very different way to the way I functioned with other people in my life. And nowadays I see quite a lot of change in that. You know, a lot of the younger doctors I talk to are very much more approachable and human, and that's from an interprofessional point of view, but there's also from the patient's perspective. Do you think moving forward there are advantages to us as health professionals bringing more of our outside persona and interests and maybe even our vulnerabilities into our workplace? Well, where do you sit on that?
That's a great question. I just considering the fairly recent history of how I think doctors are being perceived by the public. You know, if you look back to those Doctor in the House films with Dirk Bogarde as the you know, medical student, I think Leslie Phillips was in those films as well, and medical students, and then house officers, and then you know, and with Sir Lancelot Spratt as their consultant surgeon, and the way he treated them. But you know, in those days, there was a real deference towards doctors.
Yes, that's the word.
And I'm not saying for 1 minute that that's a good thing, because that kind of paternalistic approach by the profession, I think had all sorts of problems. You know, I mean, where was sort of patient autonomy, and you know, there was probably a lot of misogyny as well around in those days. So I think they were pretty dark days, but that's what the profession traditionally was. But I think it's sort of the pendulum has swung perhaps too far in the opposite direction for my liking and in my experience working as a healthcare professional in the 21st century, because I do not expect people to be bowing and scraping and rolling out red carpets for me just because I'm a doctor. As I said to you before in the conversation, I'm a human, and it's just a human interaction. And actually, there've been many really rewarding consultations that I've had over the years that have worked so well because I've brought my personality and perhaps some of my history and told them a bit about my background into the consultation. And if you have that, you know, position where the doctor's on the pedestal, that can't work. But equally, you know, now I think with some patients, they just see you as basically completely normal, and there doesn't seem to be much respect for the hard work that you've put in to achieve that job and that position, and you know, the study and the qualifications, and you know, there's like maybe this is because I'm a doctor, so I'll respect everyone, but I will respect them for different things. And if I, you know, I've had dealings with judges, you know, I've done something called marshalling, where you sit with the judge. I did that in a Crown Court for 5 days a few years ago, and I had tremendous respect for Judge Milmo, because of, you know, what he did and what he had done to get there and his experience. And I didn't put him on a pedestal. He was a nice guy, you know, but I had deference for him because of you know, his expertise, and that, you know, not just because of his position. So I don't expect for 1 minute for patients to be deferential to you just because you're a doctor or a dentist or a lawyer or a physio or an engineer, but a certain amount of respect both ways, but from the patient's perspective, because you are a learned person, you know, not everyone. Sorry. Yeah, not respect everyone can. Yeah, exactly, and the experience and the expertise and how you can help them. And I think some people just, you know, they don't get you know, we've been a lot of professions like teaching and medicine have been deprofessionalized over the last couple of decades by successive governments, and you know, I don't think that's a good thing. And I don't think it's good for patient care, because if I get someone coming in and shouting the odds at me because they have like zero respect for me and they've never even met me before, I'm a human. I can't help but let that have an effect on the relationship and the consultation.
So, would you in an ideal world see an element of professional identity as maybe a form of protection, or I'm not sure that is what you're saying really, more a stamp, or I'm getting this sense of a little bit of space between you and the patient and created by that identity, which maybe
I think that it really very much depends on the circumstances, and the patients that I have opened up to. I have earned their trust, and and I trust them, and that's why I could be open with them and tell them about an illness I've had, or a terrible work situation that I've been in, and really empathize with them. So I don't think it's a bad thing, but I don't think that should be assumed from day one of meeting a doctor, that you can just come in and treat them like, I've had patients come in and sort of never met them before and like, "Hi, Adam," and I just find that quite bizarre, and I feel uncomfortable. Different doctors are different, and I'm Dr. Harrison and they're Mr. or Mrs. or Miss so-and-so.
Yeah, so it is going both ways.
Yeah, it really is. For me, it's going both ways. So, I have that respect for them. But I just think the pendulum has swung too far the other way. And I don't think carrying on in that direction is sustainable. We've got a different generation of doctors now, younger doctors. Whether they would feel differently, I think you probably have to interview someone who's sort of 20 years my junior, who's just come out of med school, to see how they feel. But I'm having a fair amount to do with younger doctors at the moment, because I'm going on some podcasts and things and talking about medical law and bullying and things like this, and they all seem very, very sort of respectful to me. So I don't see why it would be any different so rapidly.
It is a really difficult landscape to navigate, isn't it? Not just in these times, which you might define as particularly transitional, but with every patient and with every interaction, we're having to be quite nimble, aren't we, as health professionals, and switch quite often from sometimes just because of what you pick up the patient wants from you, what kind of interaction. Some patients think, okay, yes, I've really got to engage on quite a close level here. I can see that they're open to that, and I can see the benefits of it. And then other times you have someone in front of you who think, no, actually they probably want that more traditionally professional, distant side of me to an extent. That's what they're comfortable with, and it sometimes is related to age, sometimes it isn't. And it strikes me that that's quite hard mental and emotional work on the part of the health professional to be. And then you go home and maybe 16-year-old doesn't have quite so much respect for you as you might hope your patients do. It's a bit of a dance, isn't it, sometimes?
Yeah, that's why I think that from the outset, from the first meeting with someone new, I both as a doctor or as a patient, that just a certain understanding that there's a basal level of respect for one another, and then as you proceed through the patient journey and your relationship with the patient grows over weeks or months, then if you choose to do so, and if they choose to do so, you both let down your guard a bit. And that's how I suppose I am in my personal life as well. you know.
Yeah. So would you, in going back to sort of the well-being focus of this podcast, would you have any particular tips for, with your experience, for clinicians and healthcare professionals of how to sort of play this identity thing with them, with their own well-being in mind? Are there any sort of tips for avoiding obvious pitfalls or practices that you found helpful?
So I am not suggesting that my way is the best way or the only way, and that what I do is the sort of panacea. But I personally think it's really good to leave your professional identity at work. Not just leave your work at work, but just, when I'm not working with clients, I'm then just Adam the husband, Adam the brother, Adam the son, Adam the dad, Adam the friend, who has whatever interests I have, and that serves me well, because I'm not preoccupied with my work stuff. So a healthy work-life balance, with a clear separation of professional and personal identity, for me is key.
That reminds me of a coaching tool which you might use as well, Adam. I call it bridging rituals, where you consciously adopt an activity that creates a bridge between, in this case, your work life and your home life. So I work quite a lot with health professionals, and often they'll come up with things like a particular playlist that they always put on in their car. I've got another friend who plays a meditation. Another friend who actually, at the moment, when things are so acutely difficult in the pandemic, particularly here in the UK at the moment, she goes and she has a shower in work, and that is a ritual to her. She's literally washing away the horrors of that last shift that she's just done. And it's the bridging ritual is creating this very distinct space between, not always a bad thing and a good thing, but just one persona and another, so that, maybe if some aspects of your professional persona are not the most helpful at home, you get a chance to literally wash them off.
I understand that concept. A friend of mine, Dr. Rachel Morris, who's a podcaster, a GP and resilience expert, who I've been on her podcast a couple of times. It's called You Are Not a Frog. She talks about say the journey from work to home being decompression time. That's the phrase that she uses, and I quite like that. And for me, that's I'll listen to podcasts and things like that, or phone someone up, phone a relative or phone a friend, and just kind of like totally switch into Adam mode rather than Dr. Adam mode. So
great. So just sort of drawing things to a close, Adam, is there anything else you want to say about where you're at on this sort of professional journey, things you're doing more recently?
Yeah, thank you. I think just wanted to round the discussion about professional identity off by explaining what my professional identity is now and how I feel about that. So I haven't done any clinical work since July 2019 now, which was when we moved to Australia. And to be completely honest with you, I haven't missed patient contact and all of the things around that, working in that healthcare arena at all. And I think that's not entirely surprising, because since 2014, when I was called to the bar, but I didn't pursue a legal career, I used my legal qualifications to get into medical legal advisory and consultancy work for some local healthcare organisations, and then I got into medical leadership through that almost by accident. I've been gradually developing my portfolio career with the result that my clinical time has reduced so much that when we left in July 2019, I was only working 6 hours a week as an out-of-hours GP. So once we moved to Australia, I decided I wasn't going to practice medicine at all. And I felt quite content with that. And I currently have no plans to return to patient-facing work. But I still very much define myself professionally as a doctor. And I was teaching Indigenous medical students in Darwin. And I was lecturing on their GP course to the second year students there. So I was still very much Dr. Adam, but I wasn't treating people. And now I think I feel like a doctor, but my coaching clients, who are mostly doctors and medical students, are now my patients. But it's so much better because I feel like I can give them much more time and hence better care than I ever could to my patients. So it's fantastic now, actually. Yeah.
It's really good to hear. So having weaved your way through a few different identities, it sounds like you're in quite a comfortable place at the moment, which is great to hear.
Yeah, I hope so. I hope I don't end up changing again. My wife will kill me.
Okay, let's hope it's content for a long time. Well, thank you so much, Adam. That was a really interesting conversation and journey through different aspects of identities, and things came up there which I hadn't thought of before. So thank you so much. It's been really good.
Oh, my pleasure. Seriously.
And maybe one day we'll meet in the same country. You never know. See how things go.
Oh, we absolutely will. If I don't come home to the UK and bring my daughters to see their grandparents and aunties, my name will be Mud.
It will happen. Excellent. Thank you so much, Adam. Really appreciate it.
Yeah, not at all. Honestly, it was my absolute pleasure. Thank you.
Oh, hang on. I can't let you go yet. How do people get hold of you, Adam, for your work? Are there any handles or addresses or anything you want to leave people with?
Yeah, so my email address is dr.adamharrisson@gmail.com. So dr.adamharrisson, all as one word, @gmail.com. I'm on LinkedIn quite a bit, just under Dr. Adam Harrisson. And I have a couple of Twitter accounts, but my sort of coaching one is at future with capital F, exec with capital E, and coach with capital C. Brilliant.
Thank you so much, Adam. Look forward to talking to you again soon.
Thanks so much, Joe. Take care.
Take care. Bye-bye.
Bye.
Thank you for listening, and I really hope you enjoyed that conversation with Adam. We weaved around all different aspects of professional identity, and I hope you found some things that resonated and were maybe able to take away a few tips that might help you work out how your professional identity serves you and maybe sometimes doesn't serve you in your well-being and fulfillment. I hope you will listen to future episodes of the podcast, because as a health professional, looking after other people and caring for others all day and every day, you matter.